our coding webinar. I'm Carol Ann Wilson and work as a medical officer at the MSSO and will be your instructor today. And I'm supported by my colleague Leander Mold, who was speaking to you before. So together we will take you through this webinar, which will last for about 2 hours. We would like to make this webinar interactive. Leander already mentioned this, so please really submit your questions or send us your comments through the question panel. And we will allow as much time as possible for questions, both during the course and also at the end of the webinar, at the end of the presentation. But just as a reminder, please do not raise specific coding questions, so any verbatims you came across, as we can't help you with individual verbatim terms, but of course we will guide you in terms of coding principles. Like in all our webinars, we will start with 2 standard slides with some relevant information about MedDRA and this training material. So ICH adopted the development of MedDRA in the mid-1990s and finally became the owner of the terminology. ICH then, on contract, appointed the MSSO to take care of the maintenance and further development of the terminology based on user feedback, to provide and organize corresponding training, and to administer the MedDRA licenses. And all these activities are overseen by the ICH MedDRA Steering Committee, with members of the regulatory bodies and pharmaceutical industry associations in Europe, US and Japan, Health Canada, the MedDRA in UK, and the WHO as an observer. And since May 2025, new members have joined the group, namely the Chinese regulator, short NMPA, the Saudi Arabian Drug Authority or SFDA, and a member of the International Federation of Pharmaceutical Manufacturers and Associations as an observer. ICH is not only the owner of MedDRA itself, but also owns this training material. It is protected worldwide. You may use the slides with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point on the slide refers to warranty and liability issues you should be aware of, and the third bullet point is not relevant for today. These are the topics that we will cover today. We will first discuss some more advanced principles, coding principles that are outlined in the PTC document for MedDRA term selection, which is a coding guidance document provided by ICH. We will then look into the MedDRA concept descriptions and at several advanced coding scenarios. And we will use Poll Everywhere, this application, the quiz application, and the MedDRA browser to apply some of these advanced concepts from the MTS PTC document, so the ICH coding guidance document. And finally, we will go through some tips for coding, what we call the coding pearls, to help you with your coding tasks. And we will conclude with a Q&A session, but as mentioned earlier, you will be able to raise questions throughout the session as well. The next 2 slides explain about the polling. If you would like to join the quizzes and participate in the examples today, there are 2 ways to do so. The easiest way is to scan this QR code with your smartphone or tablet. Or you may enter the indicated web address into the URL bar at the top of your internet browser in your computer, tablet, or cell phone. It will then take you to a log on screen and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but please enter my name as the username, Carol N. Wills 584, no spaces. Nothing more to be entered, just click join. And Leander has put these credentials in the chat as well. So now let's see whether technology works. Oh, it does. Oh, we had lots of people in the US. Very good morning, very early morning. We have people in South Africa, is it Botswana, Madagascar, and in Australia, Philippines, I guess, India, Saudi Arabia, welcome, Russia, dobry dzień dobry. We have people in Portugal, bon dia, buenos dias to Spain, merhaba to Turkey, and then lots of people in Europe. Greenland, good morning. So we have lots of people in Europe, but it's really distributed around the world. Interesting to see. So welcome to this webinar. I'm sitting in Berlin in Germany, and I'm really very happy to welcome you all. Let us now start with our topic today and first look at the MedDRA term selection points to consider document that provides guidance for operational coding. This is a screenshot of the cover page of the ICH PTC document for MedDRA term selection. It usually indicates the release number, the release date, and the release number. It provides guidance and many examples on how to perform accurate and consistent term selection using MedDRA. This guidance should be the basis for your in-house coding conventions, for all your coding decisions, so thereby promoting overall coding consistency and facilitating a common understanding when sharing clinical data. So MedDRA allows us to speak with one language when sharing medicinal product safety information between different biopharmaceutical companies, between pharma and CROs, or when talking to regulators. This document was developed. It is maintained by an international expert working group appointed by the ICH Management Committee, with again members from regulators and industry, the MSSO and the Japanese Maintenance Organization, or JMO, and the WHO as an observer. There is one complete and comprehensive version that is available. You see the languages here in English, Japanese, Brazilian, Portuguese, Chinese, French, Korean, Spanish, and Russian. The English version is released with each major MedDRA version release. That means beginning of March each year. The translations then follow on March 15th. In addition, there are condensed versions of the original document in other MedDRA languages, except those that I have just mentioned. And you see these languages listed on the slide: Arabic, Czech, Dutch, German, Hungarian, Italian, and Portuguese. These condensed versions focus on the general coding principles without going into further details for selected topics. They are not updated with each MedDRA release, but on an as-needed basis, because the basic principles do not change much. And you'll find these documents under the menu How to Use and submenu Support Documentation on the MedDRA website. Let me shortly show you where to find them. Here we are. Here's the MedDRA website, How to Use, Support Documentation. And here we are, Points to Consider documents on the top. Here's the MedDRA term selection, Points to Consider document in different formats. We also have a redlined version. This redlined version highlights the changes as compared to the previous version of the document. So if you are already familiar with the content of this document, you may only refer to this redlined version to easily identify the changes. And then you see a Points to Consider companion document. We will discuss it during this webinar. So this Points to Consider document addresses some topics of regulatory interest and topics that, based on experience, pose problems to the MedDRA users. It addresses the topic data quality, the topic medication errors, and the topic product quality issues. So it's always useful to look into this companion document if you are dealing with with terms, verbatims that relate to these topics. So let me go back. Here we are. The Coding Basics webinar that I've provided last week focuses on the basic principles for term selections that are outlined in the first part of the PTC document. Today, we will focus on specific coding topics, more advanced ones, that are addressed in the second part of the PTC document, and you see the list of these topics here, like diagnosis and provisional diagnosis with or without signs and symptoms, patient outcomes, suicide and health, self-harm, combination terms, exposures during pregnancy, congenital terms, and we will cover quite a few of these advanced coding concepts today, those that are highlighted in yellow, either in separate slides or via practical coding exercises. And the list goes on here with medication errors, overdose, toxicity, poisoning, device-related terms, drug interactions, indications for product use, etc. Let's first start with some important general principles which are addressed in the PTC guidance. We have already discussed them in more detail in the Coding Basics course. Coding is done on LLT level, the data entry level, and only current LLTs must be used in ongoing coding. The LLT selected should capture as much information provided by the original verbatim as possible. Basic rule for MedDRA coding: code as reported. So when coding, we should not add or also not subtract relevant medical information. As can be seen in this example, reported is an abscess on the face. This verbatim should not be coded to just abscess because it is medically relevant to also capture the manifestation site that was reported. That is why we would select LLT facial abscess to capture as much information from the report as we can, because an abscess could affect many other manifestation sites. And always remember to select current LLTs only. The non-current LLTs are still in the terminology for historical purposes to support interpretation of legacy data and legacy data conversion, but they should not be used for ongoing coding. In some instances, you may consider to select more than one MedDRA term to capture the full information of the verbatim. Selection of only one term will lead to loss of information, to loss of specificity, and you would need rules for the prioritization of the information received to ensure coding consistency, and these should be documented in your coding conventions. But you may also decide to capture the full information in split code. When taking this approach, you would duplicate the event and end up with redundant event counts. In the end, you are free to choose either option. We call it lumping or splitting. But again, make sure to document your rules and to use them consistently. And let's look at an example on the slide. If you are to code the verbatim metastatic gingival cancer, you may decide to select either LLT gingival cancer or LLT metastatic carcinoma to not duplicate the event. But you may also decide to capture the full information in split code by assigning LLT gingival cancer and LLT metastatic carcinoma. When taking this approach, you would duplicate the event that is the malignant neoplasm information. Now, how would you code when it comes to split coding? How would you code left foot and ankle swelling? Let's look at an example here. Left foot and ankle swelling. How would you approach this verbatim? Would you split code or would you try to subsume it under one LLT, to lump it? What would you do? Peripheral swelling is one option, swelling of feet and ankle swelling, So here we would split code. You could consider unilateral leg swelling when lumping it together, or local swelling because it's the left foot and the left ankle. So close together, it's a local swelling. So let's see what you're going for. Split of opinions, but most of you are voting for splitting. And so this is completely right. So thank you for joining, because we would split in this instance, because splitting swelling of feet and ankle swelling, if you look into the MedDRA hierarchy, you will see that ankle swelling is grouped under PT joint swelling, so a separate PT, and swelling of feet is grouped under peripheral swelling. So the ankle is considered a joint in MedDRA, and swelling of feet with many other terms are all grouped under peripheral swelling. So it's always worthwhile to check the hierarchy when looking for suitable terms for such a combination term, to make sure that that if you have to split code because the reported concept is represented by two separate PTs, or whether you are able to lump it all together under one PT. So thank you for joining. And well done. Most of you got it right. Now let us look at another example for this principle. How would you code pain in hand, severe pain in leg, and toe? Would you split code this reported event and code pain in hand and pain in leg and pain in toe, or would you lump the information under one of the other LLTs? How would you approach now this verbatim? Pain, musculoskeletal pain, pain in hand, pain in leg, and pain in toe would be one option. So splitting, you could select pain in extremity, or you could consider that pain in hand and pain in leg, because the toe is part of the leg. So let's see. Most of you would split code, and others would code to pain in extremity, or pain in hand and pain in leg. So let me close the poll and again look at the correct answer here. It would be pain in extremity. Why? Because LLT pain in hand, LLT pain in leg, and LLT pain in toe are all grouped under the PT pain in extremity. And under such circumstances, we would select an LLT, the LLT that is identical to the PT name, so pain in extremity. So, and again, you can see that checking the hierarchy when considering certain LLT assignments is always helpful and important. Checking the hierarchy is an important general principle for term selection, and this applies not only to check for splitting requirements. So before making a coding decision in more complex cases, it is really advisable to check the MedDRA hierarchy to reassure yourself that you are on the right track, that the selected LLT is medically correctly represented in the MedDRA hierarchy. As an example, a non-infectious condition should not be represented in SOC infections, or a condition which was acquired later in life should not be coded to a term in SOC congenital. So this slide provides an example. If you are to code the verbatim feeling completely drained, you won't find an exact match in MedDRA. You may then consider to assign LLT worn out, but may be unsure whether this is appropriate. But when checking the corresponding PT, fatigue, in the LLT siblings underneath, like for instance, LLT exhaustion, washed out, and LLT tiredness, you will feel much more comfortable with your coding decision. When not checking the hierarchy, you may even end up with a completely incorrect code assignment. If a patient suffers a ventricle rupture due to a pre-existing hydrocephalus, the selected MedDRA term should reside under SOC nervous system disorders. The correct term would be LLT, cerebral ventricular rupture, same PT. When searching for ventricle rupture and not checking the hierarchy, one may assign the LLT ventricle rupture. It seems to be a perfect match. But this LLT in PT is grouped under HLT myocardial disorders, NEC, and resides in SOC cardiac. And this is really, it's a real life example that I came across when doing spot checks of code assignments when working in pharma. So it's always useful to check the hierarchy. Another topic that I would like to highlight today are the concept descriptions. These are descriptions on how a medical concept is interpreted, used, and classified within MedDRA. They do not represent medical definitions, but they may be helpful for you when searching for suitable LLTs. The purpose of the concept descriptions is to support accurate and consistent use of MedDRA in coding and data retrieval. They intend to help to overcome differences in the use of medical terms worldwide, but because in many instances, medical terms are used differently when you look at it globally. You will find a link to the concept descriptions in Appendix B of the MedDRA Intro Guide, but you can also access them in the MSSO MedDRA browsers. If you click on the corresponding icon of the MedDRA browser, this window will open. You can then select the appropriate section to view, as the concept descriptions are sorted in alphabetical order. So let me show you again where to find it. And I will be using the new web-based browser today. So this is the shortcut to the legacy web-based browser. If you would like to use the new one, then you would go to Tools, and here open the web-based browser, open the new web-based browser. Here it is. Here's the link. Here are my credentials, and here I'm logging in. So it looks a bit different from the legacy one, but has the same functionalities. So you will find the MedDRA concept descriptions here. Here they are. If I click on it, you see the window or the screenshot that I've shown you before. So let us look into it. Cancer carcinoma. Cancer is a disease in which abnormal cells divide uncontrollable and can spread to other parts of the body, metastasize. Cancer can be one of several histologic types, including those derived from epithelial tissues, carcinomas, those derived from other tissues, I don't know how to pronounce this, mesenchymal tissue, sarcomas, and those arising from hematopoietic or lymphoid tissues, like leukemia, lymphomas, multiple myeloma. In the context of MedDRA, carcinoma and cancer are considered synonymous. Carcinoma terms are generally subordinate to cancer terms. So this kind of information you get in the concept description. So some medical information, but also how these terms are classified in MedDRA. Another one would be dose, for instance. What is a dose? A quantity to be administered at one time, such as a specified amount of medication. If I go to the O here to check for overdose, I see, for the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose in quantity and/or concentration. In other words, an excessive dose. And let us look for the same in underdose. For the purposes of term selection and analysis of MedDRA-coded data, underdose is the administration of less than the minimum recommended dose in quantity and/or concentration. And when we Especially for the product quality terms, we have some useful information in there. So, like for instance, manufacturing stability testing, etc. So, what a precipitate is, preparation, what product means compared to drug. So it's always look into the concept description, so to make yourself familiar with them, because they are really helpful to understand the meaning of the MedDRA terms that you may come across when searching for suitable terms. So do we have questions so far, Leander?
We do have one question, Caroline, that's come in. It was in relation to selecting more than one term.
Yes.
In this person's system that they use, they can only select one term.
Yes.
So what do they
The
do, and do they document? So they can add a comment. So do they document which code do they select, and would they add into the comments the extra event?
Yeah, that's always a difficulty, especially in clinical studies and in the clinical development area. Most of the drug safety databases really allow for splitting, but not if it comes to clinical studies, clinical projects. So I would recommend to really have some general rules how to prioritize the information. This may be even project-specific rules, product-specific rules, but these need to be documented. And coders, of course, need to be instructed. They should know what type of rules are set up if they are specific for projects or even studies. So it's a difficult topic. I know it's just a technical issue that certain databases do not support split coding.
Thanks, Caroline. We've had another one come in. Sometimes a report refers to one single extremity, e.g. foot, hand. But what should I do if the appropriate term is only available in the plural, e.g. feet and hands? In that case, the term would suggest that a medical problem exists in both extremities, even though only one extremity is affected.
Yeah, so this would also, so when I was working in pharma, we had a specific rule for that. We amended our coding conventions with a specific rule. So you need to have the prioritization. Either you prioritize the fact that something presents unilaterally, so then you would select a local swelling, for instance, or local erythema, but you would, of course, lose the fact that it's really affecting the periphery. Or you say, well, it doesn't matter. We prioritize the exact localization, that is the foot, even though the LLT is only available in plural. So it really depends on your product how you would approach this this coding scenario.
Thanks, Caroline. That's all the questions for now. Thank you.
Yeah, so the points to consider document does not address all scenarios. So for some scenarios that you come across more often, you would need your own coding conventions. So we will now address some of the specific advanced principles addressed in the points to consider term selection guidance document. The first advanced principle in the document is the coding of confirmed or provisional diagnosis with or without signs and symptoms. Well, we have a single diagnosis. If we have a single diagnosis without signs and symptoms, which is confirmed, we will only code this diagnosis because this is the only information that we have. If a provisional diagnosis is reported without signs and symptoms, we would take this suspect diagnosis as if it was confirmed and code it accordingly. In parallel, we would of course ask the reporter for more information, whether it was meanwhile confirmed or revised. And the same approach would be taken if you have multiple confirmed or provisional diagnoses without reported signs and symptoms. Next, we have a different coding scenario where either a confirmed or provisional diagnosis is reported with clinical signs and symptoms. For such coding scenarios, the PTC document provides a preferred and an alternative solution. For a definite diagnosis with signs and symptoms, the preferred option is to only extract and code the diagnosis. And here we have an example. Anaphylactic reaction with rash, dyspnea, hypotension, and laryngospasm. We would only select anaphylactic reaction when taking the preferred approach. And in the case of signs and symptoms that are reported with one suspect diagnosis, all signs and symptoms and the provisional diagnosis are to be coded. In case signs and symptoms are reported with several suspect diagnoses, all signs and symptoms and all provisional diagnoses are to be coded. Alternatively, again, signs and symptoms can be coded in addition to the diagnosis when having a confirmed diagnosis. So with the same example, we could not only code anaphylactic reaction, but all the signs and symptoms in addition. Or only the signs and symptoms may be coded without the single suspect diagnosis because the provisional diagnosis may of course change. Again, the same rules applies for multiple confirmed or suspect diagnosis. Both options, the preferred one and the alternative option, can be selected, but the approach chosen has to be applied consistently and needs to be documented in the coding conventions. Be aware that taking the preferred option is simpler, would lead to a leaner database, to less noise in your database. When taking the alternative approach, you would be on the safe side, not omitting reported information, but data retrieval and analysis may be more complex. However, one cautionary remark when taking the preferred approach. The PTC document clearly states that signs and symptoms that are not associated with the diagnosis, that are not typical for the diagnosis, will always have to be extracted and coded separately. And you have an example here, but this is really quite straightforward. Myocardial infarction, chest pain, dyspnea, diaphoresis, ECG changes, and jaundice. Of course, the jaundice has nothing to do with a myocardial infarction. So it's very clear in this instance. But honestly, even with sound medical background, this is sometimes hard to decide. Clinical signs and symptoms are very often not pathognomonic, meaning that they do not point at only one diagnosis, but could relate to many. So let's have a look at an example for this topic. Here we have two suspect diagnoses plus related signs and symptoms. Sepsis leading to shock from possible spontaneous bacterial peritonitis or bowel perforation. So which LRT would you select based on what you've just heard? Applying the preferred approach. You can select more than one term here. It's not necessary to search in your browser, just apply the principles we have just addressed and select the most appropriate LLTs. Two suspect diagnoses and signs and symptoms. Most of you are going for bowel perforation. Let me close the poll. Bowel perforation, spontaneous bacterial peritonitis. So these are the two suspect diagnoses, and most of you would combine the information sepsis and shock and assign the LLT septic shock. We have to capture both provisional diagnoses for sure, based on the PTC document on the preferred option. And for the provisional diagnosis, the preferred option provided by the PTC document, it asks us to code the associated symptoms in addition. So the correct approach is to code the two provisional diagnoses and the related symptoms by assigning the ALT septic shock. You may, of course, argue that the sepsis and the septic shock occur at different time points. Then you would have to split code. Then you would first code the sepsis and then code the septic shock. But here we assume that this was a sudden occurrence of the sepsis that immediately led to the shock in the patient. So then you would assign septic shock. You would document this together and this with the same date, same time point of occurrence. Are there questions, Leander?
No, just one popped in. Just bear with me.
Yeah.
In the definitive diagnosis example, signs and symptoms are listed together with the diagnosis. Could you please clarify whether these symptoms are shown only to reflect the reported verbatim and whether the preferred coding according to the PTC is still diagnosis only?
So the preferred option is to code the diagnosis only when you have a confirmed diagnosis. The alternative approach that is provided by the PTC document is to code the diagnosis and all signs and symptoms. And we, in our training material, we usually always follow the preferred approach. Okay, I hope I could.
Yes, thank you. And one more's just popped in. Would it be incorrect to ask the site to report the event as 3 AEs for septic shock, spontaneous bacterial peritonitis, and bowel perforation?
It depends on in which area you are working. So in pharmacovigilance, you would extract this information from the narrative. Then you could directly extract it in a way that it makes medical sense based on the narrative, case narrative that you have. In clinical trials, if you have an entry for a sepsis and a separate entry for the shock with the same start date, you would ask for lumping this together to septic shock. So then you can code it to septic shock. You could also decide to code one of them to sepsis and the other one to septic shock. So it depends on this. These are data entry conventions in clinical development.
Thanks, Caroline. The person came back and said, yes, they're working in devices, medical devices in clinical trials.
Yeah. Another frequent problem area in operational coding are reports with conflicting or ambiguous information, and the slide provides 2 examples from the PTC document. If no clarification can be obtained, you will have to find an adequate coding solution for such verbatims. In the first example, the diagnosis hyperkalemia does not match the lab result that rather indicates hypokalemia. The recommended coding approach for such terms is to code to the respective abnormal MedDRA LLTs. Coding then covers the fact that the lab result is not normal, but doesn't make any assumptions whether it is below or above the normal range. So this is very helpful. You would, of course, always try to clarify the background, but if you cannot clarify the background, then take this approach. Just code the investigational result as abnormal. A different scenario is shown in the second example, where we see an ambiguous abbreviation that could indicate either genitourinary or gastric ulcer pain. If we cannot obtain clarification from the reporter, the best solution is to code to the underlying basic medical concept that is pain in this instance. If confronted with abbreviations, check in some references like dictionaries for medical abbreviations in order to find out whether on an international basis these abbreviations will always mean the same thing, meaning that they are not ambiguous. MedDRA contains abbreviations, but only if they are non-ambiguous. Especially when receiving consumer reports in pharmacovigilance, vague information may be reported and there may be no chance for further clarification. Turn green here is a nice example. It could relate to the skin or tongue of the patient, but also to a drug like a capsule or cream that has changed color. So we do not even know if this is something that affects the patient. That is why we would code similar verbatims to LLT unavailable event. If we knew that there is something wrong with the patient, as shown in the second example, we should choose the LLT ill-defined disorder. So patient had a medical problem of unclear type. We would code this to ill-defined disorder if we cannot obtain further additional information. MedDRA includes several LLTs and PTs in SOC General that can be used for such vague scenarios where we know that the patient is affected, but we cannot get more information, like general symptom or local reaction, for instance. Any questions that came in, Leander?
Oh, we had one that came in about but why would you have chosen code possible conditions? So it's going back a little bit. I'm sorry, but yeah, it's still a question on why code possible conditions.
Possible conditions. Well, it's of course you have the signs and symptoms, and you have a reported provisional diagnosis, and somehow you will have to capture this because based on the clinical picture, the medic has decided that this could be the cause for the signs and symptoms. So do not omit information. The preferred option is to code everything. But as you saw, the alternative solution is to code the signs and symptoms only because, of course, also the provisional diagnosis or several diagnoses, this could change. And a follow-up report, follow-up information could reveal that it has a completely different background. So you're free to choose. Either you take the preferred approach or you take the alternative approach.
Thanks, Caroline. And then we had another one just on seeking clarification in the example of septic shock, spontaneous bacterial peritonitis, and bowel perforation. In clinical trials, this person would code 3 different events. Is that the correct approach?
Yeah, as I said, in clinical trials, you get the information from the investigator. So it really depends how the investigator is reporting it. And it clearly demonstrates that also investigators have to be trained in terms of term specification so that their verbatims really fit coding requirements. And it depends how it is reported. So if it's reported separately, you may, based on your own data management approaches, twist it a bit and come up with a correct sequence saying that this is a sepsis leading to a septic shock and encode it appropriately. But this is it's a very specific question. It's hard to provide you with a detailed answer because I do not know how your database works and what your data entry and data management conventions are.
Thanks, Caroline. That's all the questions for now. Thank you.
I think we have to speed up because otherwise we will not come to the exercises.
I know. It's great that everyone wants some questions, but
so
yeah.
I will skip this one here already and come to this one here. We have a diagnosis here that is hypoglycemia and a corresponding lab result. How would you approach this one? Would you select blood glucose abnormal, blood glucose increased, or would you just code the diagnosis hypoglycemia? Just compare the diagnosis with the lab results. Is this consistent? Is it ambiguous? Is the lab result contradicting the diagnosis? Yeah, most of you got it right. Blood glucose abnormal would be the correct assignment. We would code to blood glucose abnormal because the blood glucose is clearly above the normal range. So, and because if you don't get more information, we would always, of course, try to clarify, but if you don't get more information, we would code to blood glucose abnormal. When coding investigational results, always remember the following. MedDRA includes medical conditions in the relevant system organ classes, plus related investigational results like lab results in SOC investigations. Therefore, it is important to make this distinction. It is a fundamental rule in MedDRA that you should not change internally. Remember the basic MedDRA coding rule, code as reported, meaning that if a medical condition is reported, code as such. And when an investigational result, like a lab value, is reported, select a term from SOC investigations. Never interpret a lab test result as a diagnosis. When receiving precise reports on investigational results, like in the first example, there are no problems. The value is clearly below the reference range and the verbatim can be coded to LLT glucose low. But often, investigational results are reported without units, like in the second example. We don't know whether this refers to 40 milligrams per deciliter, which would be low, or 40 millimoles per liter, which would be high. Such reports are ambiguous and should be coded to a suitable abnormal LLT again if there is no option for further clarification. In order to classify lab values as low or high, not just decreased or increased, you will need standard references, by the way, to decide whether the reported value is clearly below or above the normal range. Quite frequently, a diagnosis is reported with the corresponding lab values. We saw some examples when looking at ambiguous terms or vague terms. In such cases, you are not obliged to capture the diagnosis plus the investigational results as long as these are consistent with the diagnosis. Because when an hyperkalemia is reported with an investigational result that supports the diagnosis, like in the first example here, elevated potassium, and the kalium is 7.0 millimole per liter. So the investigational results here supports the diagnosis. And that is why you don't have to split code. You just can code to hyperkalemia. But when would splitting of investigational results become necessary? Let's have a look at the second example, where 4 different abnormal liver function tests are reported. So increased alkaline phosphatase, increased SGBT, increased SGOT, and elevated LDH. Remember the fundamental principle MedDRA rule. Code as reported. Do not omit parts of the reported events. Always code as specifically as possible. So do not lump the reported findings under one LLT, like, for instance, LLT liver function tests abnormal, but split and code each of the specific reported findings separately. Another example for you to try. Testing showed increased serum creatinine and BUN with increased BUN creatinine ratio. How would you approach this one? Increased serum creatinine, BUN increased, blood urea and nitrogen creatinine ratio increased, or would you lump this under renal function tests, NOS abnormal? Exactly, most of you got it right. We would not lump it under a very unspecific term like renal function tests abnormal. We would code as specifically as possible by split coding and capturing each of the reported abnormalities of the lab values. So here we are. Now let's have a look at another example. This patient had features of aldosterone excess. Would you code to aldosterone increased, aldosteronism, blood aldosterone abnormal? What would you do? The patient had features of aldosterone excess. Oh, we have a split of opinions here. Most of you are going for the lab value. Let me close the poll. So let's look at the verbatim again here. Here, no investigational result is reported. We are not told that the aldosterone was measured and resulted to be excessive. But it is reported that the patient had signs and symptoms, features of an aldosterone excess. It is a condition in the patient. And that is why we would select aldosteronism. It is grouped under PT hyperaldosteronism that perfectly captures this medical condition in the patient. So clearly distinguish conditions in the patients from lab results. Here, no lab result was reported, but a condition in the patient. Are there questions?
Yeah, we had a couple of questions. So if a hospital staff or somebody reported an event and they spelt it wrong, so an example being hyperkalemia, and they put a space after the hyper before the kalemia, would you go back and ask them to correct it before you code it?
No, because it's not. If a spelling error would make the verbatim ambiguous, then you would have to go back to the investigator, to the reporter. But in this instance, this is not the case. It's still clear what is meant by the verbatim, so that's why I wouldn't go back to the investigator.
Thanks, Carol-Anne. And one other, when, if ever, should liver function tests abnormal be selected instead of individual abnormal liver enzyme results?
Only then when it's reported as such, when you get such a more vague information that the liver enzymes were abnormal in a patient with no further information, then you can select these terms, the more vague terms. But if you have specific information, you should always try to capture the information as specifically as possible.
That's it. No more at the moment. Thanks, Carol-Anne.
Thank you. Here comes the next advanced coding principle, combination terms. The first example on the slide refers to such a term, but not to a diagnosis with signs and symptoms, as we saw earlier, but to terms that relate to the same overarching medical concept, but where one is more specific than the other. And the slide shows two examples from the PTC document. Arrhythmia due to atrial fibrillation. So atrial fibrillation is the more specific type of arrhythmia. So we would code this verbatim to atrial fibrillation because atrial fibrillation is an arrhythmia. Hepatic function disorder specified as acute hepatitis. Again, we code to the specific type of hepatic function disorder, the acute hepatitis. But sometimes you'll see MedDRA combination terms which relate to two separate medical concepts. For instance, combining a defined medical condition with its etiology or additional attributes like demographic information. Remember our previous example with the sepsis and the shock, where we have found a combination term, septic shock. And here we have additional examples. So retinopathy due to diabetes can be coded to diabetic retinopathy, rash with itchy to itchy rash, and breast cancer HER2 positive can be coded to HER2 positive breast cancer. So MedDRA contains such combination terms. It's always worthwhile to look for them. But if you get a verbatim representing combination of relevant clinical information and no corresponding combination term is available in MedDRA, then you should split code. You should select more than one LLT to capture all relevant medical information. In the first example, we would split and code to LLTs diarrhea and vomiting, two separate PTs in MedDRA. We wouldn't lump this information under a more vague LLT like gastrointestinal upset, for instance. In the next example, a wrist fracture due to a fall is reported. Again, capture all information. The fall may have been caused by the drug because it made the patient feel dizzy. So you have to capture all information to be able to search for it in your database, to be able to look for patterns and safety signals. And then we have a reported BRAF positive malignant melanoma. Again, split this information to capture both the specific malignancy and the gene mutation because it is relevant for therapy decisions and for the prognosis of the patient. So here splitting would be necessary, and in all of these instances, if you get these terms, such verbatims in clinical development, you would go back to the investigator, to the reporter, and ask for documenting this information in two separate AE fields. An example for you again. Here, retinal disease from HIV with near total blindness of both eyes is reported. What would you do with this one? Would you go to retinal disorder, HIV disease, blindness, HIV retinopathy, and or blindness both eyes? HIV retinopathy seems to be the preferred approach here, and blindness both eyes. And this is perfectly right. So we have a reported retinal and HIV disease and could split and select retinal disorder and HIV disease. But HIV retinopathy is a perfect combination term for this retinal disease from HIV. MedDRA contains quite a number of such combination terms, so look out for them and use them. Now, do we have to consider additional information in our verbatim for coding purposes? Yes, we have to code the subsequent complication by assigning LLT blindness, both eyes. This finding cannot be considered a symptom of the reported HIV retinopathy, but represents a late-stage serious complication of the disease. That's why we would capture it separately. And here we are. We would code to HIV retinopathy and blindness, and most of you got it right. Excellent. So let's see again if you have questions. Do we have questions, Leander?
No, none at this time. Thanks, Caroline.
Okay, let's continue. The next advanced topic are medication errors, and the slide shows the concept description for the term medication error. A medication error is or are defined as any unintentional and preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. So the last part is really important. So medication errors occur during medication use in the clinical setting. Medication errors have nothing to do with anything that occurs during manufacturing or distribution of the medication to pharmacies whatsoever. So only when it comes to the clinical setting, then we are talking about medication errors. If a medication error is reported with clinical consequences, like in this example, patient was administered wrong drug and experienced hypotension, both the medication error and the consequence of the error needs to be captured. So the closest matches are LLTs, wrong drug administered, and the LLT hypotension. If a medication error is reported and it is made clear that there were no clinical consequences, the PTC guidance provides us with two coding options again. When it is reported that an intramuscular formulation medication was given by another route, the preferred option would be to code the medication error, the wrong route of drug administration alone. The most specific LLT would be intramuscular formulation administered by other route. The alternative approach would be to not only capture the error made, but also the fact that no subsequent complications occurred by assigning LLT no adverse effect. So again, you are free to choose either option, but document your rules and ensure that they are applied consistently. Sometimes potential medication errors are reported. Such incidents should also be captured as specifically as possible. Also, contributing factors should be captured, like in this example from the PTC document, where it is reported that a pharmacist notices that the names of two drugs look similar and is concerned that this may result in someone getting a wrong drug. LLT drug name look alike captures the information about the contributing factor, and LLT potential for medication error, wrong drug, indicates that there is a potential for a medication error, including the error type. Why do some regulators want to receive this information and are actually very keen to receive such information? Well, in such scenarios, no medication error happened yet, but could of course occur in the near future based on the reported contributing factors like drug name confusion, etc. When understanding the background for these potential errors, regulators can take steps to prevent these errors even before happening. So depending on your local requirements, do not omit such information, but capture all relevant information when receiving similar verbatims, and code both the potential for an error by selecting one of the LLTs under the PT potential for medication error, and the contributing factor, of course, in addition. Any questions? Other questions, Leander?
Yes, Carol-Ann, sorry about that. Just trying to get my button unmuted. For medication errors, injecting technique when a drop of blood is getting into the injection, and when a drop of blood or when a drop of blood or drop of drug is coming out of the needle.
So this is a very specific question again. We really have to hurry a bit because otherwise I'm afraid that we can take this and provide you the answer with via email.
Yeah. Okay, that's great. And one more, just on the blindness, the near blindness. Do we need to capture blindness when it is only near?
Well, there you have to look into the PT, the LLTs under this PT. So it depends on the severity of the blindness, and there are some LLTs under the PT blindness that really reflect a severe loss of vision, and then we have the visual impairment. In addition, the PT that would be selected if you have a partial vision loss.
Thanks, Carol-Ann. That's it for now. Thank you.
And if it's relevant for your purposes, you would anyhow try to, for your drugs, you would anyhow try to get more information about the degree of impairment, and then you should have a scale when to consider something as blindness and when not. So that's something that really depends on your product portfolio. So to better understand the concepts representing medication errors, please refer to the PTC document for MedDRA term selection, because you'll find very useful information in there that will help you understanding how to use these challenging terms. And also, like mentioned at the beginning, look into the MedDRA points to consider companion document, because this document provides even more detailed guidance specifically around medication errors and much more examples to help distinguishing the different concepts. In addition, you'll find many MedDRA concept descriptions for the medication error terms and other types of unauthorized product use like intentional misuse, drug abuse, drug dependence, or off-label use. And the MSSO offers additional, more detailed training options for the topic, like a webinar, MedDRA Coding of Medication Errors, General Principles. You find the recorded sessions on our YouTube channel for this. We have a learning management system I will refer to at the end of the session to explain where to find it, how it's, what the intention of this learning management system is. And under special situations, there's also examples, explanations about medication errors and other relevant videos on our MedDRA YouTube channel, as I told you already. So let's again look at some examples. Here it is reported that syringe plunger couldn't be completely pushed down, so the patient received only half of his scheduled dose. So we have obviously something that is wrong, something didn't with a syringe here, and then because of that, the patient received only half of a scheduled dose. Would you consider this a missed dose, partial dose delivery by device, syringe issue, or would you select wrong dose administered? What would you do? Yes, exactly. You're on the right track here. Both the device issue and the consequent medication error needs to be captured, obviously, as there are multiple reasons why the plunger couldn't be pushed down, like a malfunction of the device or product design issue. LLT syringe issue is the appropriate term to keep it more vague. And the resulting administration error also has to be captured. Missed dose would be incorrect because some medication was administered. Wrong dose is too vague. We know it was a reduced dose, a partial dose, and therefore LLT partial dose delivery by device would best fit this verbatim, would be the most specific term. It is linked both to the SOC product issues to reflect the product quality issue and to the HLT product administration errors and issues in the injury SOC. So here we are. We will now address a more specific topic that may also relate to medication errors: overdose, toxicity, and poisoning. If overdose, poisoning, or toxicity is reported, extract this information and code accordingly. Poisoning by drugs and drug toxicity are considered synonyms in MedDRA. You will find the relevant terms under PT toxicity to various agents. You may ask yourself when to consider a reported higher dose as overdose. Well, we saw the concept description in the browser. It says, for the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose, either in quantity and or concentration, in other words, an excessive dose. If an overdose is reported with clinical consequences, you would code both the overdose and the resulting events. If there are no clinical consequences, again, you have two options. The preferred option provided in the PTC document asks to code the overdose only, but you also have the alternative option to select both overdose and no adverse effect. Again, let's try. Next, it is reported that a patient unintentionally took more than the maximum recommended dose due to a dispensing error. So what would you do with this one? Accidental overdose, incorrect dose administered, or would you and or drug dispensing error. I think this is quite straightforward. Always try to code as specifically as possible. So we have the information that more than the maximum recommended dose was administered. So this definitely reflects or represents an overdose. And we have the information that it was unintentionally administered. So accidental overdose would be the correct assignment here. And we, of course, also have to capture the stage where this error was made. It was a dispensing error. So both would need to be captured. Here we are. Always capture the stage where the error occurred and the specific error if reported. Another advanced principle addressed in the PTC document is death and other patient outcomes. Death, disability, and hospitalization represent patient outcomes and seriousness criteria and are normally not captured as adverse events or adverse reactions. But if one of these outcomes is the only information that is received, that is reported, then you would code as specifically as possible. And also, if a death term would add relevant medical information, you would code it in addition. Here an example. Patient experienced a rash and had sudden cardiac death. If you would ignore this information, sudden cardiac death, and not capture it, you would of course omit relevant clinical information because it can be considered unusual that a rash leads to a sudden cardiac death unless the patient had additional medical problems. So under such circumstances, you would always split code. Suicide and self-harm is another special topic addressed in the PTC guidance. When coding suicide attempts, completed suicides, and self-harm, clearly distinguish these scenarios. Be as accurate as possible and handle these terms consistently. Do not assume that an overdose, even if it is reported as intentional, relates to a suicide attempt. Same holds true for reports on self-injuries. If suicide attempt or suicide are not mentioned in the report, only code the intentional overdose or self-injury. Remember again the basic coding principle: do not interpret what has been reported by adding information. Code as reported. And if a suicide attempt has a fatal outcome, make sure to capture it as completed suicide because it's a separate PT. The outcome makes a big difference here and needs to be considered when coding. And this was actually what an inspector checked in a drug safety database of a pharmaceutical company. He asked for all cases that were coded to LLT suicide attempt, but with fatal outcome in order to assess the quality of data entry and coding in this database. Based on what you just heard, which of these LLTs would one select for a reported death from cerebral hemorrhage, for instance? The verbatim specifies an event, a medical event with its outcome. So options would be sudden death, cerebral hemorrhage, or brain death. As just discussed, in such cases, we do not need to code the death of the patient because it is an outcome and captured in a separate data field as a seriousness criterion. In our case, the reason for death is reported, and this is what we should capture. And LLT brain death means something different. It means that the brain has lost its function, but the patient must not be dead, but maybe comatose and depend on life-sustaining measures. So the best approximation here, we would code to cerebral hemorrhage. So before going into the next advanced coding principle, do we have questions, Leander?
We do have a couple of questions. Thanks, Caroline. For the example with the plunger, we code syringe issue and incomplete dose, but there is a device plunger issue in MedDRA. Would that be a better term to code it to?
Device plunger issue, let me check. And where it is grouped under. Ah, yes. If I click on it, it is under device issue. So yes, device plunger issue, it depends on your coding conventions. You see that dependent on what you prioritize, the device type or the actual component of the device that that didn't work as expected. So here you see that we have a device plunger issue, but on the PT level, it's grouped under device issue. You lose the information that it was a syringe that had a problem. So it depends again on your coding conventions. This is again something, especially when you work in the area of devices, where you need coding conventions in order to provide instructions to the coders what to prioritize, the device type or the device components.
Thanks, Caroline. And if an overdose is reported without adverse consequences, why is coding overdose alone preferred rather than coding overdose plus no adverse effect, given that overdose could be interpreted as implying symptoms?
Yeah, but it must not, yeah, but it depends again on the drug. So this is something again where you can choose. And if you have, of course, when you have products with a very narrow safety margin, then you would rather prefer to use the alternative approach and really capture the fact that no adverse reaction occurred. But in other instances, you may prefer to not code the fact that no reaction occurred. It's your choice.
Thanks, Caroline. And just on the slide that you're showing at the moment, why do we only code cerebral hemorrhage and not death as well? It is clearly stated in the term, nothing to doubt about.
Yes, but
Splitting.
you capture it in a separate database field. It's a serious criterion, both in clinical trials as well as in drug safety. So you would capture it anyhow, a serious criterion, fatal outcome.
Thanks, Caroline. That's it for now. Oh, hang on. One's just popped in. Let me just check. Oh, no. They're saying thank you. Thank you for your explanations.
Okay. So next one, drug interaction. Oh, I really have to speed up a little bit. Otherwise, you would be disappointed because we won't capture so many exercises afterwards. The next principle relates to drug interactions. This term drug interaction covers interactions between drugs, including biological products, but also between drugs and foods, drugs and devices, alcohol, etc. If an interaction is reported, then capture the interaction and the subsequent medical events. Here an example, torsade de pointe with suspected drug interaction. So you would code both the drug interaction because it was reported, and you would code the medical event torsade de pointe. But what if a reporter does not specifically state that an interaction occurred, but only mentioned that 2 or more drugs were taken together and reports a medical event afterwards? So in such instances, you should not assume an interaction just because the patient has taken several drugs, but select terms for the reported medical events only. So what would you do with this one based on what you just heard? After taking an antihistamine along with her prescribed proton pump inhibitor, a 53-year-old woman developed vertigo. Would you code drug interaction NOS, not otherwise specified, vertigo subjective, vertigo, or drug interaction? what would you do? So here we are. Most of you are going for vertigo, but some of you would also split code and capture the a drug interaction. But the drug interaction was not reported, as mentioned earlier. The points to consider document clearly indicates that you should not assume a drug interaction if a patient takes more than one drug and suffers a certain medical event if it's not reported. So if it's not reported, do not assume anything, do not assume a drug interaction, but code the event only. In this instance, it would be vertigo, because the vertigo is not subjective. We are not told that it is subjective, that it's only a feeling of the patient or imagination of the patient. So we should code as specifically as possible, but we should not add information in these instances. So we would only code the medical event vertigo. Any questions related to this one?
Is there a code for possible drug interaction?
Not to my knowledge. I still don't know MedDRA by heart.
I know. Well, there's over 90,000 terms, aren't there? So I know it's very difficult for that to happen.
Drug interaction. Let's look for it. Drug alcohol labeled, no possible. Vaccine, pharmacogenomic potentiating, but no. There is no.
Nope. That's it, Caroline. I know you want to get onto the coding exercise, and I'm sure so. Thank you.
Just shortly, as already demonstrated last week at the Coding Basics webinar. So whenever you're coding, the first thing to do is to look at the verbatim. Check the verbatim in order to understand what has been reported, whether it was an indication, a test result, a medication error, device issue, procedural complication, whatsoever, or a combination of these. Because the type of reported term will influence where you would look in the browser to find the closest LLT or LLTs that best match your verbatim. Here again, the QR code to access the poll questions, just in case you have lost the connection. And then here, how to access the browsers. So the legacy browser you can access on the MedDRA website with this shortcut, and the new one that I'm using today you can open here. When you check how to use, click on how to use, tools, and then you will see this window will open and you can open the new web-based browser. Here are the credentials, but it's a temporary demonstration password only, so it will expire in a few days from now. And Leander has put these credentials in the chat as well. So here we are, our first verbatim. It is stated that a man had a decreased fertility. So how should we approach this verbatim, which would be just code infertility, fertility decreased male, infertility male, or fertility decreased. Let me switch to the browser. And here we are. When I search now for fertility, oops, we see that we have that MedDRA makes a distinction here between female and male fertility, because of course the etiology of the infertility or decreased fertility is very different when it comes to female or male fertility decreased or infertility. So that's why we have separate PTs for these conditions. And we have a male one, infertility male, but what we have in our verbatim was a decreased fertility in a male. So let's see whether we have male here. Fertility male decreased. Here it is. If I click on the plus sign, I will see that it is grouped under PT infertility male, but we would always try to be as close to the verbatim wording of the verbatim as possible. And because a decreased fertility was reported for this male patient, we would assign fertility male decreased. So here we are, fertility decreased male. Next one, became colorblind in adolescence. We have several options again, color blindness, blindness color, color blindness acquired in American and British English spelling. So what would you do with this one? Your turn again. Became colorblind in adolescence. Let's see what you're going for. Yes, it's of course an acquired condition. Yeah, it was acquired in adolescence. It's not a congenital one. Let me close the poll. Here we are. It's really the key thing that the color blindness is normally a congenital disorder, and that is why it is this PT here, color blindness, is placed under the congenital SOC in MedDRA. But because we are told that the patient became colorblind in adolescence, we will have to look for a term which includes the information that the condition was acquired. And here we are. So this is something, some of these terms do not contain the information congenital. So this is another area where it's important to really check the hierarchy before assigning an LLT. Color blindness is grouped in primary SOC congenital. And if you have an acquired one, like in this instance, then you would have to look for a MedDRA term that contains the information acquired. Check the hierarchy in these instances. Other questions, Leander?
No, not at the moment. Thank you, Caroline.
Next one, turned very greasy. What is reported here? Is it would we code it to ill-defined disorder when we cannot obtain any clarification what is meant by it? Unavailable event, skin greasy, unavailable reaction. What would we do? Next, your turn. Turned very greasy. Remember what we discussed before about ambiguous verbatims and vaguely reported events. If you cannot get more information, what would you do? Do we know what turned greasy here? Unavailable event. Well done. Most of you got it right. Excellent. Because here it could, of course, be the skin or the hair or whatsoever. It could something that affects the patient, but it could also be a product quality issue. It could be a cream or a tablet that became greasy. So here we definitely don't know whether the patient was affected or whether this verbatim relates to a product quality issue. And that's why we would assign unavailable event. Next, a patient experienced a medical problem. So how would you handle this? We had this before. How would you handle such verbatim? Would you code adverse event, unavailable reaction, or ill-defined disorder? Patient experienced a medical problem. Very vague term. Let's see what you're going for. Ill-defined disorder. Correct. Because here we are told that it's a problem that the patient suffers. So it's not that we don't know whether it relates to a product or device issue whatsoever. We know the patient had a medical problem. So that's why ill-defined disorder, based on the points to consider document, would be the correct code. So coding to LLT adverse event would imply that the patient was exposed to a medicinal product or study drug. And we don't know that. It could also be an event in the follow-up period. And the reaction term would even imply causality. So the correct assignment here is ill-defined disorder. Next one. A 2-year-old boy accidentally took his mother's medication. Which LLT would you select for this one? Accidental product intake by child, accidental exposure to product by child, accidental drug intake by child, or unintended ingestion of product by child. Be as specifically as possible. A 2-year-old accidentally took his mother's medication. So it was not his medication. It was his mother's medication, so it was an accidental exposure. He took it, he ingested it, and it was a drug. Always look at the verbatim in order to understand what has been reported here. Accidental drug intake by child, exactly. This would capture everything. It would capture the accidental exposure, the demographic information that we got, that it was a child, a toddler, and that it was a drug that was taken. Product is more unspecific, could be something else, could be a device as well, and it's not accidental overdose was not reported. We don't know what type of drug was taken, and we don't know the dose. And unintended ingestion of product by child would also be, it's a product term, so we know it was a drug. That's why we would code to accidental drug intake by child. Just interrupt me, Leander, if we get questions related to these exercises.
Will do, Caroline. Nothing at the moment, but thank you.
Infection after surgery is our next verbatim. So what would you select here? Infection, postoperative wound infection, surgical wound infection, or postoperative infection? Let me switch to the browser in order to show. So if I just enter infection here, I get a lot, of course, a lot of different infections. Lots. You see 2,590 hits in MedDRA. Postoperative wound infection, we were not told that the surgical wound got infected. So surgical wound infection, same problem. Our verbatim said infection after surgery. We are not told that it was the surgical wound that got infected. But what about postoperative? Oh, spelling, I'm not good in typing. Opera. So, post-procedural, post-operative infection. Here we have post-operative infection is grouped under post-procedural infection. So we have a number of terms. So if you get a report on a medical condition, medical event that is suffered by the patient after a procedure or after a surgery, then look out for these combination terms that capture the timely relationship to a procedure. So if I just look for post and op, you see that we have a lot of post-procedural terms here, complications, very specific ones, and also post-surgical terms, anemia, so lots of. So it's always worthwhile to look for them. Here we are. Post-operative infection would be the correct assignment. He sold his father's medication. Options are drug diversion, intentional product misuse, drug use for unapproved indication, or intentional drug misuse. Some of you, especially the non-native speakers, may not be familiar with the term drug diversion, so therefore it can be helpful to consult reliable resources, and for this term we even find a MedDRA concept description in the browser. It states that for the purposes of term selection and analysis of MedDRA-coded data, drug diversion means that a drug is diverted from legal and medically necessary uses toward illegal uses. So the term drug diversion refers to a scenario where a drug that was legally used for medical reasons is sold to another person for an illicit use. And you see some of the commonly diverted drugs listed on the slide, like benzodiazepines, opioids, amphetamines. If no concept description would be available, consult medical dictionaries, like the Dorlands, for instance, or medical textbooks, or internet resources, like the Merck manual, so MSD manual, the professional version. It's available in several languages for free on the internet. It's really a good resource. And also you could, of course, use Access Medicine or Up to Date, but you will have to pay for it. And but there's also on the internet there are clinics, so renowned clinics like Mayo Clinic, website whatsoever, Cleveland Clinic, that really provide a lot of very useful medical information. Here the correct term selection, we would, here the son sold his father's medication. So it must have been something where a black market exists, because he sold it, and this is definitely a drug diversion. Next, it is reported that the patient accidentally missed her morning dose. How would you code this verbatim? Would you select missed dose, temporary interruption of therapy, intentional dose omission, or missed dose in error? So let me again switch to the browser. So if I say missed dose, here missed dose in error, we have a missed dose and a missed dose in error. So if I go to the browser, I can check this LLT in its hierarchy. And now we see all the terms that are grouped in the HLT product administration errors and issues. And we have the missed dose. Here we are. Product dose omission issue. Here we are, missed dose. But we have the product dose omission in error. Forgot to take product, missed dose in error. So, and of course, we also have intentional off-label uses and intentional product misuses. Intentional product misuses and intentional product misuse. You would use one of these if you have an intentional dose omission. Temporary interruption of therapy was the other option. Takes a while. Here it is. If I click on it and say open details and occurrences, I can see the term in the hierarchy. Here we are. Temporary interruption of therapy is grouped under surgical and medical procedures. So this LLT should be used for situations where the dose omission was due to non-clinical or external factors like a supply, insurance, financial issue, where the patient could not afford the medication, when it was not accidental or intentional. And usually it would relate to something for a longer time period. Let me switch back. So the correct assignment would be missed dose in error. This would capture the full information. It was accidental and one dose was missed. Next, the doctor made an error while prescribing a medication. the pharmacist noticed the error and did not dispense the drug. Which of these LRTs would you assign? Wrong drug dispensed, medication error, intercepted drug prescribing error, intercepted drug dispensing error. Your turn. Doctor mistakenly prescribed the wrong drug. The pharmacist noticed the error before dispensing the drug. Who made the error? Exactly. You're on. Excellent. Intercepted drug prescribing error would be the correct assignment. There is no evidence that the wrong drug was dispensed because the pharmacist intercepted the error made by the doctor. LLT medication error would be much too vague. The PTC document clearly states that the intercepted error term should reflect the stage at which the error occurred, not the stage at which the error was intercepted. So the pharmacist did nothing wrong in this instance. The error happened at the prescribing stage. So intercepted drug prescribing error would be the correct assignment. Well done. The next example is quite straightforward. A patient reported a loss of smell and thought that she might have a COVID-19 infection. So anosmia, suspected COVID-19, loss of smell, and COVID-19 would be our options. So it was not a definite diagnosis, but a suspect diagnosis plus a related clinical symptom, and therefore suspected COVID-19 is more appropriate than LLT COVID-19. And based on the preferred option in the PTC document for MedDRA term selection, we would code both the suspected diagnosis and the related symptom. So loss of smell and suspected COVID-19. Again, anosmia is the medical term for loss of smell, but we would always keep as close to the verbatim as possible. Next, it is reported that the dose taken was below the minimum recommended dose in the product label. So is this an underdose? Is it just a drug administration error? Accidental underdose? Incorrect dosage administered? What could we do with this one? So underdose, again, if I show the, underdose, here we are again, is the administration of less than the minimum recommended dose. So this is exactly what has been reported here. So what we have here is an underdose. An underdose was reported. And we say the dose taken was below the minimum recommended dose in the product label. So we do not have any information whether this was intentional or accidental. So we would go to a neutral term just to underdose. And if I enter underdose in the browser, you will see that there are several options: accidental, intentional, prescribed, radiation underdose. But here we have the underdose. And if I go to the browser, where is it? Here it is. Under HLGT overdoses and underdoses NEC, underdose, here it is. This is a perfect assignment. Yes?
Caroline, could I take you back to the COVID-19 example? I have a question on it, if you don't mind.
Yeah.
The question is, but she thought she had COVID-19. Do we have to code that also, as it will depend on the PT?
So we would code she thought she had. So she is not sure. It was not confirmed. It was not confirmed by a test or whatsoever. It was just an assumption. That's why we would code suspected COVID-19. It's an LLT. It's a separate PT. And it was included in MedDRA when we had the pandemic, the COVID-19 pandemic. And then we have the information about the symptom of the patient, the loss of smell. And because it's a suspect diagnosis, we would code both based on the preferred approach outlined in the PTC guidance document.
Thank you, Caroline. That's all for now.
Next one, because his package of medication contained too much drug, the patient accidentally received an overdose of medication and developed severe nausea. He was diagnosed with gastritis. So what could we do with this one? Would this be a product physical issue? Would this be a package volume overfill when looking at the package of medication contained too much drug, how to capture this? The patient received an overdose. Would we have to code this to overdose or accidental overdose? And then he developed severe nausea that was diagnosed as a gastritis. So we would take the preferred approach again. So what would we capture here? Accidental overdose? Yes, because nothing indicates that the overfill of the package was intentional. So this was definitely something accidental, and therefore also the overdose is an accidental overdose. Product physical issue would be too vague. We have more specific information, so package volume overfill would be the correct assignment here, the most specific LAT that we can select. And because he was diagnosed with a gastritis, this is the diagnosis. Nausea is the typical sign of a gastritis. So that's why we would only code gastritis based on the preferred option for a confirmed diagnosis in the PTC document. Here we are. And most of you got it right. Excellent. She was abused by her husband is the next one. What do we do with this one? Physical abuse, battered wife, spousal abuse, victim of spousal abuse. What shall we do with it? Let me go to the browser again and let me enter spouse and abuse and search. Something wrong? Yes. Better to use word stems because spousal, the LAT is spousal abuse. And you see we have two different LATs here. Spousal abuses, so the criminal activity per se, and the spousal abuse, and the victim of spousal abuse. Two separate PTs here. So victim of spousal abuse and spousal abuser. Here we are. And if I go to let me close it and go to browser. You see it's grouped under social circumstances. We have an HLT for crime victims and an HLT for criminal activity. So the spousal abuser is grouped under criminal activity, whereas the crime victims, and here we have a reported crime victim, is grouped under crime victims, HLT. So let's now explore the HLT victim of abuse. We have a victim of abuse, very vague. Victim of spousal abuse is the best battered wife, would be incorrect. We don't know what type of abuse this woman suffered, whether it was sexual abuse, whether it was verbal abuse, psychological abuse. We don't know. So that's why victim of spousal abuse would be the best choice here. Here we are, victim of spousal abuse. Next, the patient was treated with drug Z for rosacea, which is an off-label use of this medication. Unfortunately, she developed severe dizziness. So rosacea would represent the indication for use. It was used off-label in this indication. So shall we assign off-label use an unapproved indication or off-label use? And she suffered dizziness. How would you approach this verbatim? You will have to capture all information, like always. The indication for use, the fact that it was used off-label as specifically as possible, and the subsequent adverse event in the patient. So you would code the rosacea, at least in pharmacovigilance, as indication for use. If it would be the indication for use for a specific project, you would not need to code it in clinical development, but it's definitely an off-label use and unapproved indication in pharmacovigilance. You would only get such a report in pharmacovigilance. So off-label use and unapproved indication is the most specific LLT that you can assign for the off-label use. And you would, of course, also capture the dizziness. The rosacea would be the indication for use. Here we are. Rosacea, off-label use and unapproved indication, and dizziness. 27-year-old woman took 2-week course of antibiotics during her pregnancy. She did not experience any side effects. Here are 3 options. What would be your choice? Maternal exposure during pregnancy, that's clear. Would you code no adverse effect in addition? And or normal pregnancy. So here a screenshot of the related guidance in the points to consider document. When a maternal drug exposure during pregnancy is reported that has no clinical consequences, the preferred option is to only select the term for the pregnancy exposure. Alternative, so if you have a clinical consequence, then you would only code the maternal exposure during pregnancy. Alternatively, again, you could code the fact that no adverse effect occurred. So in the same chapter, you also find guidance on how to handle coding of events in the child or fetus when the mother or father is exposed to a medication. So with this, we would code to maternal exposure during pregnancy. Selecting the term normal pregnancy in addition would be wrong. We know that the antibiotics did not cause any side effects, but the pregnancy may still be abnormal because of concomitant diseases of the mother, for instance, or pre-existing abnormality of the fetus. So we cannot assume that it was a normal pregnancy. And we would not select a term for no adverse effect when taking the preferred approach recommended in the points to consider document. And it is not reported whether the exposure took place in the first, second, or third trimester, because we have specific LLTs for this information. That is why we would select a more general LLT here, maternal exposure during pregnancy.
Caroline, just on that one, I had a comment, if I may. In a clinical study, we would follow the pregnancy until birth to observe whether congenital effects have been reported.
Yes. Yes, of course. So this is based on regulations of health authorities. And you would always, in such instances, try to find out what the outcome of the pregnancy is. But here we don't have this information. Yeah, you would always ask for follow-up information. So I think we will have to skip here, because otherwise we will not be able to cover all our, so what we So we have missed 3 examples. I think it's not too much. I tried my best to really show all the examples. We missed 3, but I would now like to come to the coding pearls, what we call the coding pearls. So first, I would like to emphasize that MedDRA can not only be used for adverse event coding, but also for coding of indications for use, medical history data, risk factors, investigations, medical procedures, etc., etc. So this slide gives you an example of case information in a narrative format that those of you who are working in drug safety are very familiar with. We are provided with information of the indication for use of the drug that is taken by a 75-year-old male. We get information about his medical history and risk factors, the development of an AE, that is an area of darkened skin on his chest, a surgical procedure to treat the condition, and a final diagnosis. It turned out to be a seborrheic wart. And all underlying concepts in this narrative can be captured with MedDRA. Here are some valuable tips for you. Whenever you are searching for a suitable term for a verbatim or for terms from a narrative, like we saw before, first try using the actual wording of the reporter. You better use work stems, as you saw in my example with the spousal, like for example, also pancreas to cover both pancreas and pancreatic for your search. Because if you are too specific in your search, if you use plural terms, for instance, instead of singular terms, you may not find any results. And you should use singular terms, replace words with synonyms if you don't find a suitable hit in MedDRA, like for example, replace intentional by deliberate or unintentional by accidental when coding errors in medicinal product use. Or if you have a drug that is used for prevention of a certain disease, look for prophylaxis terms. If you have found a somewhat suitable term, be aware of MedDRA specificity and always look for LLTs under the same PT that may even better capture the verbatim, and also look for sibling PTs in the same grouping, in the same HLT, because there may be PTs that are better matches to your verbatim that include additional information, like for example, demographic information, acute or chronic information, post-procedural occurrence, etc. Remember the example where we looked at the verbatim reporting a drug exposure by child, where we saw that there is a PT for accidental product exposure, but also a separate PT for accidental product exposure by child. And if you have found a suitable term, always check the hierarchy, very important, where the term lies in MedDRA, in order to reassure yourself that the hierarchy represents your reported condition correctly. Remember our example with the acquired color blindness. If we had chosen color blindness, it would have been in the congenital SOC, and that hierarchy would be wrong for our coding scenario because the verbatim was referring to an acquired condition. When searching for suitable terms, use the top-down and bottom-up navigation, and if you have difficult verbatims, use available resources for clarification, among those also the concept descriptions that you can find in the MedDRA browser. The advanced search function is not yet available in the new web-based browser, but we are working on it. But you can narrow down your searches by restricting your search to a SOC when needed, for example, when you get a long list of potential hits in the browser. And of course, you should get more coding training and of course, coding practice via a high coding turnover. The more you code, the more experience, the more professional you will get, the more accurate and consistent your coding output will be. So this is what we covered today. And this is now the last chance for questions. Do we have questions, Leandro?
No, we've had a lot of positive feedback, thumbs up. They've really enjoyed it, and somebody's asked about how you get your certificates. So just a reminder, you download them yourself through the self-service application, but don't do it today. It takes 2 business working days in order to access it. I'll put
Okay.
the link in the chat for
Mhm.
everybody.
So just a reminder on some links to useful information to the browsers, to our website, how to submit a change request. Here is the link to the tool, how to submit it, training schedule, and to the support documentation. So all the support documentation, the points to consider document, but also the MedDRA introductory guide. So this is what you find under the schedule, training schedule website. This is the training that we have today. You see where we provide this webinar in different languages: French, Chinese, Brazilian, Portuguese, Spanish. And if you would like to revisit some basic coding principles, here are the MedDRA Coding Basics webinars in French, in Korean, and the next one in English on 27th of May in a different time zone. There are additional offers for coding training. The Let's Code Together sessions in workshop format are provided for more advanced and experienced coders. So this is the one that Jane, my colleague Jane, and I provided on Tuesday this week. There's another one in Chinese in June. So, and we will provide additional ones in English in Central European time zone in the second half of the year, 2 of them. Then the MedDRA Learning Management System that I mentioned here is a webinar especially about this new tool for learning purposes, how to access it, how to use it. And also, if you're not familiar with the web-based browsers that the MSSO offers, there's also always tool demonstrations that you can find. The next one in Russian, but watch out for them. This web page is continuously updated with new offers, with new training offers. Here again, the learning management system. So it's a self-learning system, a controlled environment that contains these self-learning videos. You are guided through it through a predefined learning path. There's beginner and advanced levels, certificate and non-certificate tracks, and important to know, an unlimited number of accounts per organization. It was launched last year. And here are some examples. You have an overview of MedDRA coding and analysis of MedDRA coded data. Here's some of the more advanced coding scenarios, outcomes, suicide, social circumstances, pregnancy, and also, so this is just a selection, there's much more to find in there, medication errors, etc., etc. And also interactive MedDRA coding options where you can test your knowledge yourself. So here's the link to it, and also the QR code, how to access it. This is the last thing that I would like to show you. You can, of course, follow us on social media and also in WhatsApp and WeChat groups. What I would like to show you is our YouTube channel. If you have our website and you click on contact, let me show you. Here we have our website. If you click on contact and you click on this icon here, YouTube, then you have all the recorded sessions of the different trainers that work for the MSSO in different languages with different topics. So you see Heber, our colleague in Egypt. You see Fernando, who works in Brazil. My colleague Anne, who is also German speaking, French, Nicola, and also American people or trainers that work in America and in the US. So watch out for them. Also, this training session will be posted on the YouTube channel. Here is my account. So if you did not attend the MedDRA Coding Basic course, then of course you would be able to watch this course on this channel that I provided last week. So, or the one from another trainer because everyone has a different style, or a trainer that really presents in a different language. So this was what I wanted to show you. And with that, sorry, we went a little over schedule, but I hope you found this webinar useful. And I also hope to meet you again in 1 hour trainings. With this, I would like to thank you for your interest and your active participation in today's webinar. And also a big thank you to you, Leander, for supporting me today with all these questions.
Thanks, Caroline. It was great. As always, I learned something new from you every time we do it. So thanks, everyone. There's a couple of questions we'll need to follow up with, but I'll let you have those, Caroline,
Okay.
afterwards. And
Thank you.
thanks, everyone. Enjoy the rest of your day.
Yeah.
Bye-bye.
Goodbye for now. Bye-bye.